Hi everybody, and welcome to our module on pulmonary anatomy. In clinical medicine, when we talk about patients who are sick, especially patients with infections, we usually divide the respiratory tract into an upper and lower respiratory tract. The upper tract includes structures like the nasal cavity, the pharynx, the larynx, and the lower tract basically includes everything from the trachea down below, including the bronchi and the lungs. In terms of pulmonary physiology, however, the respiratory tract is usually divided up into zones. The conducting zone is the portions of the respiratory tract where there's no gas exchange and air is simply conducted back and forth. So this includes parts of your respiratory tract like the large airways, the nose and pharynx, the trachea and bronchi. There's no gas exchange in any of these areas, but they conduct gas to the alveoli where gas exchange occurs. And in addition to conducting air, the conducting zone is also important for filtering air. A lot of particulates are removed here. It also warms and humidifies air. And in the video on ventilation and perfusion, I talk about anatomic dead space. Dead space means a section of the respiratory tract that fills with air but does not participate in gas exchange, and the conducting zone makes up much of our anatomic dead space. And then the other zone of the lung is the respiratory zone. This is the portion of the lung that feeds the alveoli directly where gas exchange occurs, so this includes structures like the respiratory bronchioles, the alveolar ducts, and the alveoli. Here's a picture of the lower respiratory tract. The trachea delivers air into the lungs. It branches into two primary bronchi, one that goes to the right side and one that goes to the left side of the body. The primary bronchi then branch into secondary bronchi, tertiary bronchi, and eventually they branch down to very small tubes that conduct air to the alveoli called bronchioles. And then at the end of all these conducting airways, you find the alveoli, which is shown over here on the right. These are the sacs where gas exchange occurs with the blood. And here's a picture just to make this very clear in your mind. Here we have a terminal bronchiole. This represents the final, most distal structure in the conducting zone. It branches into two respiratory bronchioles here, which deliver air directly into the alveoli. And then connecting the respiratory bronchiole to each alveoli is a very small alveolar duct, which is also part of the respiratory zone. So the conducting portions of the lower respiratory tract are made up of bronchi and bronchioles, and the difference between bronchi and bronchioles is the presence or absence of cartilage. The bronchi are surrounded by cartilage and the bronchioles are not. And as I told you before, the trachea branches into primary bronchi, which are also called the left and right bronchi. From there, the bronchi branch into secondary or lobar bronchi, and then tertiary or segmental bronchi, and then they go on to branch more and more until they form the bronchioles. The bronchioles also branch. They begin with lobular or large bronchioles, and they branch till they form terminal bronchioles and finally respiratory bronchioles, which feed the alveoli. And the goal of all this branching is to increase the surface area for ventilation. The more surface area you have, the more oxygen you can take up and the more carbon dioxide you can remove. So therefore, by branching into smaller and smaller structures, you create lots and lots of surface area for gas exchange. Let's talk about some of the cells you can find in the respiratory tract. Goblet cells are cells that secrete mucus. Mucus is made up of mostly glycoproteins and water. As you may know, if you've ever blown your nose, it's very sticky. And its role is to protect against particulates. It captures a lot of particulates in the air and does not allow them to travel down to the alveoli. It also protects against infection. Other cells in the airway are the ciliated epithelial cells. These cells have beating cilia that move the mucus towards the epiglottis where it is ultimately swallowed. And then in the bronchioles, there are specialized cells called club cells. These are non-ciliated epithelial cells that secrete protective proteins. They also detoxify the air. They have P450 enzymes and can metabolize toxins that are present in the air to protect the alveoli. So here's an illustration of the respiratory epithelium just to make it clear in your mind. We have some particulate that has been caught up in a layer of mucus. There's a goblet cell that produces the mucus, and then there is ciliated columnar epithelial cells which contain cilia that is beating and moving the mucus up in this direction towards the esophagus. The respiratory epithelium changes as you move from the trachea and bronchi to the bronchioles. In the trachea and bronchi, what you find are ciliated pseudostratified columnar epithelial cells, and this is also where you find goblet cells that secrete mucus. In the bronchioles, the epithelium slowly transitions and eventually becomes a ciliated simple cuboidal epithelium. And you do not find goblet cells in the bronchioles, but that's where you find the club cells that I talked about before. Those are found in the terminal bronchioles. The walls of the conducting airways contain smooth muscle. So for example, your bronchioles can constrict or dilate to allow more or less airflow. This smooth muscle is innervated by the sympathetic and the parasympathetic system. Beta 2 receptors are activated by the sympathetic system, and this leads to bronchodilation. So basically, as part of your fight or flight response, you want the bronchioles to dilate and allow more air into the lungs. Conversely, the parasympathetic system can constrict the bronchioles. This is called bronchoconstriction through M3 receptors, and this is what happens in the rest or digest phase of the parasympathetic system. Here's a picture that you can find in any pulmonary physiology textbook. It shows the zones of the lung and the structures that make up those zones. The conducting zone is on top, and the transitional and respiratory zone is down on the bottom. So you can find cartilage and goblet cells at all levels down to the bronchioles, which is right here. Smooth muscle is present to some degree around all of the conducting airways down to the alveolar ducts. And then cilia is found at all levels down to the alveoli. Let's talk about the resistance to airflow. The upper airways constitute about 50% of the resistance to airflow. This includes structures like the nose, the mouth, and the pharynx. Once you get down into the lower airways, the highest resistance is in the medium bronchi, and let's talk about why that's the case. If you look at the bottom of the screen, this is a famous pulmonary physiology graph that you'll find in many physiology textbooks. On the x-axis is the air vessel size, starting from the largest vessels, the trachea on the left, to the smallest vessels, the bronchioles on the right. On the y-axis is resistance to airflow, and it turns out that resistance to airflow is highest in the medium bronchi. So why is that the case? Well, there's lots of turbulent flow in the medium bronchi because the bronchi are branching a lot at this point. In addition, the total surface area of the medium bronchi is very small. Even though they're somewhat larger structures, there are only a few of them. In contrast, the terminal bronchioles are very tiny structures, but there are thousands and thousands of them, such that the total surface area is very large. So in the terminal bronchioles, you have a large area for flow, so you get slow laminar flow. And in the medium bronchi, you have turbulent flow and a smaller area for flow, so that's where you get the highest resistance to airflow. Now that we've talked about the airways, let's talk about the alveoli. Alveoli are small sacs separated from one another by walls called septa. They are lined by a single layer of epithelial cells, a simple squamous epithelium, and we call the epithelial cells in the alveoli pneumocytes. And as you know, alveoli are where gas exchange occurs. They're surrounded by capillaries so that carbon dioxide can go out and oxygen can go into the bloodstream. On the top right side of this slide is a picture of what the alveoli look like under the microscope. The large white areas are the air sacs, and the epithelial cells are lining those air sacs. Those are the pneumocytes. The most common epithelial cell you find in the alveoli is the type 1 pneumocyte. This makes up 97% of cells, and these cells are very thin in order to allow for gas exchange. Less common are the type 2 pneumocytes. These epithelial cells produce surfactant, which we'll talk about in a minute. In addition, these cells can proliferate to form other cell types, and for that reason, they're very important for regeneration after injury. This is a classic board question. A patient with pneumonia who a few weeks later has a completely normal chest x-ray. Which cell led to this normal chest x-ray? It's the type 2 pneumocytes that allowed regeneration of that damaged lung tissue. And then finally, you can also find macrophages in the alveoli. Now let's talk about surfactant. So when you exhale, your alveoli shrink, and your alveoli are very small structures and they could easily collapse. This leads to what's known as atelectasis, or collapse of lung tissue. And collapsed alveoli are bad for gas exchange. So the reason we have evolved to produce surfactant in our lungs is to prevent the collapse of alveoli so that we can maintain gas exchange. As I mentioned earlier, surfactant is secreted by the type 2 pneumocytes in the alveoli, and it's a mix of substances called lecithins. Lecithins are all lipid-like substances, and the most important one is dipalmityl phosphatidylcholine. They may ask you this on your exam, so you should be aware that this is the most important lecithin, and lecithins are what make up surfactant. To understand surfactant, we have to first understand surface tension. So your alveoli are lined with a thin film of liquid, and the liquid-liquid forces tend to pull the surface area together and form a sphere, and we call those liquid-liquid forces surface tension. So the law of Laplace is an equation that is used to determine the collapsing pressure of the alveoli, and this is related to surface tension. The collapsing pressure is the name for the forces that tend to collapse the alveoli. And if you understand this, it should be easy to understand that a low collapsing pressure is good. That means there are relatively few forces trying to collapse the alveoli, and it's easy for an alveolus to remain open. In contrast, a high collapsing pressure is bad. This means there are lots of forces trying to collapse alveoli, and it's difficult for an alveolus to remain open. And so the law of Laplace says that the collapsing pressure is equal to 2 times the surface tension divided by the radius. So the law of Laplace has important implications for our lungs because our lungs contain many small alveoli. Small alveoli have a very low radius, and the term for radius is in the denominator of the collapsing pressure equation by the law of Laplace. So a small radius means a very high collapsing pressure, which is bad. So in order to balance out this small radius and keep our alveoli open, we need to have really low surface tension. And that's what surfactant does. It reduces the surface tension so that the collapsing pressure will not be high. It also has an effect on lung compliance. Compliance is how flexible the lungs are, and surfactant tends to increase lung compliance, meaning they become less stiff and more floppy. So here's a picture just to make this very clear. If we could have really large alveoli, that would be wonderful because large structures have a low collapsing pressure. Unfortunately, we don't. We have millions of small alveoli in order to make for a large surface area for gas exchange, and those small alveoli have a high collapsing pressure. But if we add surfactant and break up those liquid-liquid forces surrounding the alveoli, we can convert that high collapsing pressure into a low collapsing pressure, and that's what our lungs do. Even though we have a small alveolus, because we have surfactant, the collapsing pressure is low, and the alveoli tend to remain open. The most important clinical tie-in of surfactant and collapsing pressure and the law of Laplace has to do with fetal lung maturity. So basically, the baby has to remain in the womb until the lungs are mature so that the baby can breathe. And the lungs become mature only when there's enough surfactant present to keep the alveoli open. And this doesn't occur until around 35 weeks. And this is why babies that are born premature have trouble breathing. It's because they don't have enough surfactant present. You can determine whether or not the lungs are mature by measuring something known as the lecithin to sphingomyelin ratio, or the LS ratio. Basically, the baby produces both lecithins, which are a component of surfactant, and sphingomyelin at equal quantities until about 35 weeks. After about 35 weeks, the amount of lecithins begins to go up. So if the ratio of lecithin to sphingomyelin is greater than 2 in the amniotic fluid, it suggests the lungs are mature. So sometimes if we want to deliver a baby early, but we don't know if the lungs are mature, we can sample the amniotic fluid, and if the LS ratio is greater than 2, then we know that the lungs are probably mature. Babies that are born before their lungs have enough surfactant will develop what's known as neonatal respiratory distress syndrome. This entire syndrome can be explained by a deficiency in surfactant. As a result, the alveoli have high surface tension, they have a high collapsing pressure, the alveoli tend to collapse and cause atelectasis, the lungs are stiff and they have poor lung compliance, and the baby will develop hypoxemia and elevated PCO2 because of poor ventilation. In addition to all these problems, another thing that's bad about neonatal RDS is that it's poorly responsive to oxygen supplementation. It would be nice if we could just give these babies oxygen and they would improve, but the lungs tend to be collapsed, and collapsed alveoli don't participate in gas exchange. This means that blood flows across the alveoli without picking up oxygen. This is a condition known as intrapulmonary shunting, which I talk about in more detail in the video on hypoxia. But when you have shunting, adding oxygen to the inspired air will not improve hypoxemia. The major risk factor for neonatal RDS is prematurity. If the baby's born before there's enough surfactant in the lungs, that's going to lead to neonatal RDS. Babies born to mothers with diabetes have an increased risk of neonatal RDS. That's because moms with diabetes often have high blood sugar, and therefore the baby develops high blood sugar. That leads to insulin levels that are high in the baby, and this can decrease surfactant production. And then finally, cesarean delivery is associated with an increased risk of neonatal RDS. This is believed to occur because the baby does not get the stress response at delivery. Vaginal delivery is very stressful to the baby, and the baby produces lots of cortisol. If the baby is delivered by cesarean section, there's reduced fetal cortisol, and cortisol drives surfactant production. So these babies will be born without that cortisol surge. So neonatal RDS is bad because it affects gas exchange in the baby, but it's also bad because there are a number of complications that can develop when the baby does not have normal lung function. First one is bronchopulmonary dysplasia. I talk about this in more detail in the video on pulmonary embryology. But babies with neonatal RDS are often administered oxygen, and high concentrations of oxygen can lead to toxicity, which can cause the lungs to not develop normally. The lungs are still developing at the time of birth and in the neonatal period. The process of alveolarization, which is part of lung development, does not progress normally, and that's what leads to bronchopulmonary dysplasia. And babies that have this problem can have respiratory problems during infancy. Second problem that can happen is a patent ductus arteriosus. So normally when oxygen levels rise, this closes the ductus arteriosus, but babies with neonatal RDS have hypoxia, and this can keep the shunt open. And then finally, babies can have problems with the eyes. Retinopathy of prematurity is a condition where high amounts of oxygen administered to the baby to oxygenate the blood lead to free radical formation in the eye. This can cause new blood vessel growth in the retina. This is called neovascularization, and as a result, the retina can detach, and this can potentially lead to blindness. There are ways to prevent and treat neonatal RDS. If a baby is going to be delivered preterm when it's thought that there won't be enough surfactant present, The mother can be administered betamethasone. This is a corticosteroid, and as I told you before, steroids stimulate surfactant production in the baby. And then babies who are born with neonatal RDS can be treated with surfactant. It can be administered via an endotracheal tube, and this can improve outcomes in babies with neonatal RDS. Now let's talk about the lobes of the lung. The right lung is divided into 3 lobes, the upper, middle, and lower lobe. The left lung is divided into only 2 lobes, the upper lobe and the lower lobe. And the reason the left lung only has 2 lobes is because it has to make room for the heart. There is a small structure called the lingula that is a lobe-like structure and would otherwise be a left middle lobe, but it's not considered a lobe in and of itself. The lobes are separated by fissures. This fissure here on the right is called the horizontal fissure, and this one down here is called the oblique fissure of the right lung. In the left lung, there's only one fissure, and this is called the oblique fissure of the left lung. The most important thing to know about the anatomy of the lungs is how to identify which lobe is infected in the case of lobar pneumonia. So let's go through some X-ray examples of infection of each of the 5 lobes. This picture shows infection of the right upper lobe, and it's fairly easy to identify that there's a white haziness, a consolidation present in the right upper portion of the lung. That's the right upper lobe. Here's a pneumonia involving the right middle lobe. You can see this haziness here in the lung. Sometimes you can think this is the right lower lobe, but if you look on the lateral chest X-ray, what you always see in a right middle lobe pneumonia is this triangular shape right here. When you see that in the lateral X-ray, then you know that what you have is a right middle lobe pneumonia and not a right lower lobe pneumonia. And then finally, here's a right lower lobe infiltrate where the haziness is down at the bottom portion of the right side of the lung. Notice that it obscures the diaphragm border over here. That's classic for right lower lobe pneumonia. On the left side, here's an upper lobe pneumonia. You can see this haziness here in the upper portion of the left lobe of the lung. And then finally, here's an example of a left lower lobe pneumonia. Let's talk about foreign body aspiration, because this is a way that step 1 often tests your knowledge of the lobes of the lung. So foreign body aspiration can occur in any body, but it commonly occurs in children. They sometimes aspirate peanuts or small toys into the lungs. And what you need to know is when this happens, the object is most likely to end up in the right lung. The reason for this is because the right main bronchus is wider than the one on the left, and also it's got less of an angle. So when the trachea branches into left and right, the angle is less going into the right, and that's where an aspirated object is most likely to end up because it has the more vertical path into the right lung. So about 60% of cases, aspiration ends up in the right lung, usually in the main bronchus. A small number of cases are in the right lower lobe bronchus. The left lung happens in a minority of cases, about a quarter. It's usually the main bronchus. A small number occur in the left lower lobe bronchus. And here's a reference at the bottom of the screen here if you want to find out where I got all this information from. Shown on this slide is the relationship between the pulmonary artery and the respiratory tree. So the structure in purple here is the pulmonary artery. It branches into a left and a right pulmonary artery. Up top you have the trachea coming down and then branching. This is called the carina, where the trachea bifurcates into the right and left main stem bronchi. You've got the left one over here and the right one over here. What you need to appreciate is that on the right side, the pulmonary artery passes anteriorly to the right bronchus. You can see that here. It's passing in front of it towards the chest wall. That's anteriorly. On the left side, what happens is the pulmonary artery goes up over the top of the bronchus. It's superior to the bronchus. And people often remember this by the mnemonic RALS, right anterior, left superior. And on a board exam, they may show you this in a CAT scan, so let's go through that now. So over here we have the left lung, and over here we have the right lung. The carina is here. These 2 black holes represent the bifurcation of the trachea into the left and right main bronchi. You've got the aorta back here, that's the descending aorta, and the ascending aorta right here. And this is the pulmonary artery here, and you can see it bifurcating into the left and right pulmonary arteries. And the right one here goes in front of the bronchus. You can see that right here. It's anterior to the bronchus. It's toward the front of the chest. The left one here is going over the top of the bronchus, and it's a little hard to appreciate this in a 2D image, but you can see that it looks different than the one on the right side. Next, let's talk about the mediastinum. The mediastinum is the space between the lungs in the chest cavity, and it's divided into 3 anatomical compartments: the anterior, middle, and posterior mediastinum. And the way this comes up clinically is there are a number of masses that can arise in the mediastinum, and the differential diagnosis of the mass varies by which compartment contains the mass. Here's a CAT scan through the mediastinum, and let's go through the structure. So we've got the heart right here. This is the aorta right here. In the back we have the spine, and in the front we have the sternum right here. The anterior mediastinal compartment is everything I'm marking with my white pen right now. It's everything anterior to the pericardium between the heart and the sternum. The middle compartment is what contains the heart and the great vessels, and then the posterior compartment is what contains the spine and the spinal cord. On this slide, I've listed the three mediastinal compartments and the major structures that are found there and the masses that arise in those compartments. So let's go through the anterior one first. In the anterior mediastinum, that's where you find the thymus and the internal mammary arteries and lots of lymph nodes. Masses that arise here go by the mnemonic the terrible T's, and we'll talk more about this in a minute, but the reason they're called the terrible T's is because the masses tend to be thyroid, thymic neoplasms, teratomas, or terrible lymphomas. In the middle compartment, that's where you find the heart, the pericardium, the great vessels, the airway, the esophagus. Masses here are usually enlarged lymph nodes that can be from lymphoma or sarcoidosis. It's also a classic location for lymph nodes of metastatic lung cancer. And then finally, the posterior compartment contains the spine and the spinal cord and nerves. So masses back in this section are usually neurogenic tumors, things like schwannomas and neuroblastomas. So now let's talk about those anterior mediastinal masses that go by the mnemonic the terrible T's. Masses that arise from the thymus are half of all anterior mediastinal masses. One of the classic ones is a thymoma. This often occurs in association with myasthenia gravis, and I talk more about this in videos on neuromuscular junction disorders in the musculoskeletal section. Teratomas or germ cell tumors in adults develop in the anterior mediastinum. This is the most common location for an extranodal germ cell tumor. So many germ cell tumors arise in the testes or the ovaries, but some of them arise outside of those areas. Those are called extranodal germ cell tumors, and the most common location is the anterior mediastinum. So you can see teratomas here and also seminomas, which are a germ cell cancer. Lymphomas often develop here. They go by the mnemonic terrible lymphomas to fit with the four T's. And then finally, thyroid growths can occur in the anterior mediastinum, causing a mass. Some patients have enlarged or ectopic thyroid tissue that arises here. It's usually connected to the thyroid gland. Next, let's talk about the diaphragm. So the diaphragm is a muscular structure that separates the thorax from the abdominal cavities. So any structure that needs to pass from the chest into the abdomen needs to go through an opening in the diaphragm. And there are three important structures that need to pass from the chest into the abdomen, and each one goes through an opening in the diaphragm. The openings are called a hiatus. So the inferior vena cava goes through here. This is called the caval hiatus. The esophagus goes through right here. This is called the esophageal hiatus. And then finally the aorta goes through right here, and this is called the aortic hiatus. The openings in the diaphragm are not all found at the same level of the thoracic spine. Remember that the diaphragm is dome-shaped, and therefore you can find some openings that are higher and others that are lower. The first opening is the caval opening. This is found at T8, and this is where the inferior vena cava passes through the diaphragm. And it's easy to remember that this is found at T8 because vena cava has 8 letters in it. The second opening is the esophageal hiatus. This is found at T10. The esophagus passes through here and also the vagus nerve. And it's easy to remember that this is found at T10 because the word esophageal has 10 letters in it. And then finally, the aortic hiatus is found at T12. This is where the aorta passes through the diaphragm, also the thoracic duct and the azygos vein, and it's easy to remember that this is found at T12 because the words aortic hiatus have 12 letters in them. The diaphragm is innervated by the phrenic nerve, which arises from C3, C4, and C5, and many people remember the mnemonic C3, 4, and 5 keep the diaphragm alive. Now, these nerves also sense pain from the shoulder, and what this means is that if there is irritation of the diaphragm, this can lead to pain that is perceived as being in the shoulder. This is called referred pain. So even though the irritation is with the diaphragm, the pain is referred to the shoulder and the patient will complain of shoulder pain. The classic example is gallbladder disease. Some patients who have cholecystitis will complain of shoulder pain when it's actually their gallbladder. That's the problem, irritating the diaphragm. Lower lung masses can also do this. And then finally, if the diaphragm becomes irritated, this can also cause dyspnea and hiccups. And this is because the diaphragm begins spasming and not contracting appropriately. If the phrenic nerve is cut, and this sometimes happens during thoracic surgery, this will lead to the diaphragm being elevated on one side. It will also lead to dyspnea because the patient won't have normal contraction of the diaphragm. If you examine the diaphragm during inspiration, what you see is what's known as paradoxical movement. One side of the diaphragm goes down during inspiration. That's what should happen. But the side where the nerve has been cut will go up actually. It's pulled up by the other side, so it moves up with inspiration. And you can see this on fluoroscopy. It's called the sniff test. If you think a patient has had damage to the phrenic nerve and they're complaining of shortness of breath, you have them take a sniff of air in under fluoroscopy, and you will see that paradoxical movement, and that's how you can diagnose phrenic nerve damage during a thoracic surgery. So now let's talk about how we use our muscles when we breathe. Quiet respiration is the term used to refer to breathing you do when you're sitting and not thinking about breathing. It's the automatic sort of breathing that your body does. And this type of respiration is entirely performed by the diaphragm. The diaphragm contracts, and that draws air into the lungs for inspiration, and then the diaphragm relaxes and air flows out of the lungs as a passive exhalation process. When you exercise, however, you start producing lots of carbon dioxide and your lungs want to ventilate more, so they will draw in other muscles so that more air can be pulled in and blown out. Muscles that are added in during exercise include muscles in the neck. These are muscles like the scalenes, which raise the ribs, and the sternocleidomastoids, which raise the sternum. Also, muscles of the abdomen are used to make a more forceful exhalation. This includes the rectus muscle, the internal and external obliques, the transverse abdominis, and the internal intercostals. And when patients are in respiratory distress, for example, a patient with pneumonia or heart failure, or maybe pulmonary embolism, you will see them using what's known as accessory muscles. All these muscles on the slide here are accessory muscles. They're not normally used during inspiration and expiration, but in patients in respiratory distress, trying very hard to move oxygen in and out of their lungs, you will see them using these extra muscles of breathing, and we call that use of accessory muscles. It's a sign of severe respiratory distress. And that concludes our video on pulmonary anatomy.